Okay, so good morning, everyone, and thank you, Professor Jermar, for a nice introduction, my friends. And I'm very honored to present in front of all of you, and I would like to also address my gratitude to the VSSM committee, Professor Quang, and also the another colleagues from Vietnam, and also especially from the GAF for inviting me. So in this session, I will present the 6th editions of the WHO, the Manual of Cement Examinations, and what's new and what does it mean for the clinicians. First of all, I have no potential conflict of interest to disclose. And for this presentation, I will discuss on the overview of the male infertility and introduction to the cement analysis, what is the basic examinations, what is the extended examination, and what is the advanced test, and the strength and weakness and opportunity, or then the threat of the WHO of the 6th edition manual. And for a quick reminder, infertility is the inability of the sexually active, the non-contracepting couple to achieve a pregnancy in 1 year. And globally, 10 until 15% of the couples are infertile, in which the male contributes to the 40 until 50% of the factors. And there are known factors such as the varicocele, the obstructive azoospermia, and the congenital abnormalities, but there are also the idiopathic, which has abnormal sperm parameter, and the unexplained factors, which has the normal zoospermia. And all of these factors should be evaluated from the semen analysis. And the semen analysis is considered as the cornerstone for the male infertility evaluations. It is important as it is the part of the diagnosis, the treatment, and even the evaluation of the male infertility. And the importance of the semen analysis is to assess the diagnosis, to assess the male reproductive health, to guide the management, and also to guide the choice of the ART procedure, and to monitor the response to the treatment and measure the efficacy of the male contraception. And both notable guidelines, EAU and the American guidelines, strongly recommend the use of the semen analysis for male infertility evaluation. However, the semen analysis poses some limitations, as some parameters are subjective, the high variability of the observer's result both in the same or different labs, and vulnerable to human errors and difficulty of the standardizations. And the graph also show the intra-individual variability of the semen analysis, and also the concentration and also the motility, the result over time due to the biological and the lifestyle factors from only a single fertile donor. And these limitations shape the guidelines to recommend at least conduct 2 consecutive tests. And to provide a standardized sperm analysis evaluations, the WHO provided a laboratory manual. And it took more than 10 years to release a new edition of WHO 6 editions. And the latest editions provided the guidance and the standard reference to enable the reliability and also the comparability of the results. And from the European Association of Urology also recommended the use of the latest edition of the WHO manual, which is the 6th edition. And we summarize the major changes in the WHO manual in this table. And the standard examination became the basic examination to note that it is a robust routine procedure. And then the optional examination was changed to the extended examinations, which is only routinely used in certain situations. And then the research sections became the advanced examination, which further highlight that this section is not considered routine as the initial evaluation, but may be conducted if needed. And now we are getting into the more details on the updates of the latest editions. Some additional details on the pre-examination procedures were updated on the lubricants, the sample handling, and also the sample transport informations. And the lubricants are only used if they're absolutely necessary, and use a non-spermatotoxic lubricant for these situations. And for the sampling handling, the sample container should be kept at the ambient temperature, which is 20 until 37 degrees Celsius before the collections. And then furthermore, if the sample were collected not in the lab, the specimen container should be kept close to the body, under the clothes, for instance in the armpit, and transported within 30 until 50 minutes after the collections. So this information should be specifically instructed to the patient. And moving on to the basic examination, the odor are mandatory to be reported in the macroscopic properties of the ejaculate, as it may be useful in the clinical situations. And some components are changed. In the microscopic components of the semen analysis, the sperm count are detailed, and the readoption of this distinction of the progressive motility from the 4th editions, and more detailed description and the classifications, and also the vitality are indicated when total sperm motility is below 40%. And the 6th editions also altered the morphology schematic drawing. So the greater the number of the high quality micrographs of the normal, the borderline, and also the abnormal spermatozoa, along with the explanations for their classifications also were presented in the WHO 6th edition. And some reference values were adjusted with the additional more than 700 ml. And semen volume, the sperm concentrations, the total motility, the progressive motility, the immotile spermatozoa, and the vitality were adjusted. And the interpretation of the WHO 6th edition should be very careful. And the reference range cannot be used to distinguish the fertile and also the subfertile men, and no longer used as a cutoff to determine the normal range of the semen analysis. And the term of the normozoospermia, the astenozoospermia, the necrozoospermia, and the teratozoospermia are no longer used. Meanwhile, the European guideline consider the segregation of the abnormal semen analysis may still clinically relevant in the daily clinically practice. And the statement about the reference value are further strengthened by the American guidelines of the urology, which said that the WHO lower limits are based on the lowest 5th percentile of the values, and falling below the lower limit do not by themselves predict either the infertility or the infertility. And to make it clearer, let's apply the information into this case, like a young couple in their 30s is unable to conceive for more than 2 years, and the male patient is remarkably fit and healthy without any identified risk factors or abnormalities. And the semen analysis showed the total motility of 15% and no progressive motility was found. And the semen analysis reflects a reduction of the sperm total motility. Then what should we do next? And of course, we need to repeat the semen analysis within 2 or 3 weeks. And if the sperm total motility is still persistently below 40%, the vitality test should be recommended. So the 5th percentile of value are only one way to interpret the result, and the finding may suggest a possible male factor infertility. And moving on to the extended examinations. So this section is only used in certain situations by choice or the request to dig more deeper understanding in sperm functions. So the sperm DNA fragmentations are considered the most discussed and the promising addition in the workup of the male infertility. And the update on the genetic and the genomic testing highlighted the increasing of the awareness of the genetic related the male infertility. And furthermore, the anti-sperm antibodies and the leukocytes were moved from the basic to the extended examination. And the sperm DNA fragmentations are the result of the sperm DNA damage, which occur at the level of the testicles, epididymis, or after ejaculations. And overwhelming the DNA damage may beyond repair of the oocyte, then impair the fertilizations and also the embryogenesis. And the sperm DNA fragmentations are the result of the damage from the intrinsic and the extrinsic factors to the vulnerable sperm. The SDF may cause the infertility, impair the reproductive outcomes after the IUI, the IVF, and also the ICSI, and increase the risk of the genetic or the birth defect. The SDF testing are possible with the tunnel, the COMET assay, the ACSA, and also the ACD or the halo test. The tunnel test take a nucleotides that link to the DNA break, which showed by a fluorescent sperm. And this is the most used method. The COMET assay technique separate the fragmented DNA the electrophoretically and interpreted through the shape of the comet tail. while the ACSA work by the denaturating of the susceptible sperm DNA and colored metachromatically with acridine orange, and then orange red sperm are the denaturated of the DNA. The ACD test or the halo test also use the denaturation process, but it used the chromatic dispersion to observe the halo and in a healthy sperm. And among these techniques, the cutoff values are various, but the adverse outcomes are generally associated with the level above 20 until 30%. And it also should be noted that testing should be done after the ejaculatory abstinence for 2 until 5 days. So even though the SGF testing is very useful to assess the infertility cause, it has no globally accepted reference ranges and no clear recommendations by the society guidelines. So each lab must develop its own reference range based on the appropriate controls. And furthermore, the clinical utility of the FDF has never been discussed. So those reasons were thought to be the cause of the SDF testing delay in the clinical practice. And the Global Andrology Forum or the GAF experts recommended the SDF testing in some conditions. The SDF testing can be used at the diagnosis of the unexplained male infertility or after the assisted reproductive failure. And in idiopathic male infertility, the SDF testing is used prior to initiation of the assisted reproductive technology. Regardless of the semen analysis, the SDF testing should be done in the recurrent pregnancy loss couples. And when associated the conditions, the risk factors, and the exposures were identified, the patient should be informed that they are at the increased risk and the testing should be considered. So for the patients with the varicocele, the initial evaluation for the SDF is recommended, especially if the assisted reproductive technology is planned or after a failed mechanical treatment. And furthermore, the men with the persistent infertility post-vasectomy repair should also offer the SDF testing. On the other hand, the SDF testing is not performed in the subclinical varicocele unless to seek the alternative cause of the infertility. And in the ART planning, the SDF testing may be offered, but its limitation should be discussed. And for the sperm cryopreservation conditions, the SDF testing is based on case-by-case, the clinical of the basis. So in the 6 editions, the advanced tests aim to gain the deeper insights into the biological basis of the factors and to functionally assess the competence of the spermatozoa to fulfill the fundamental process essential to the conception. And the human oocyte, the zona pellucida binding, and the oocyte penetration tests are now considered obsolete. The latest editions included the seminal oxidative stress, the sperm acrosome reactions, the functional analysis of the transmembrane ion flux, and the transport in the sperm, and the methods for the chromatin condensation evaluation. And let's dive deeper into the oxidative stress assessment. So the oxidative stress are the balance of the Rhos and the antioxidants. So therefore, the seminal Rhos, the antioxidant, and also the redox state can be evaluated. So the seminal Rhos are measured by the chemiluminescence, which is the most sensitive and the specific test. The flow cytometry, the thiobarbituric acid reactive substance, and also the nitro-blue tetrazolium. The antioxidants are measurable with the total antioxidant capacity assay, which is rapid but expensive with the limited sensitivity and also the specificity. So both the Rhos and the antioxidants are measured through the redox state, which can be done in the oxidation, the reduction potential, or ORP. And it is clinically useful oxidative stress biomarker in the sperm samples. And discussing about the oxidative stress, we have to remember that the antioxidants may not always good. So the antioxidant market is quite fast and unregulated, we know. And so the physician should be cautious in choosing the antioxidants. So we have to aware that overuse of the antioxidants now can cause, the name is reductive stress. So which can also be dangerous to the cells and known to cause cancer and also the cardiomyopathy. So these effects possibly can affect the male infertility, so they highlight the need of the personalized treatment based on the redox of the state. So to further discuss the 6 WHO editions, the Boitrel et al. Summarized the SWOT analysis of the manual. So the manual has extensive data with the additional population to further represent the sample provided the updated and also the detailed lab, the technical guide, and also the quality control. And also they already introduced the SDF and also the FIS as the extended test, and acknowledged the 5th percentile of the semen analysis as insufficient for the infertility diagnosis. However, this manual still has the underrepresented data from the South America and the Sub-Saharan Africa, lack the reference threshold to replace the 5th percentile of the semen analysis, and lack of the indications and the criteria for interpreting of the SDF testing, and the lack of cut-off extended sperm analysis.
I think these specific issues.
Sorry?
I think the specific. So you make a really great talk between the old guidelines, new guidelines, and then you have made a clever move exactly to the use for the indication for SDF and now for ROS. I think the strength and limitation we should stop right now because we're running over time. And I think we should right now go ahead, if it's okay for you, because this question we have time to discuss at the end of the first 3 lessons. So take your questions, because that's the limitation, something which we can discuss. We need more time for that reason. For that, I will propose that after the first lesson, we have time, half an hour, to discuss about this in detail. And so now it's my pleasure that I will pass to my co-moderator to invite the next presenter. Please, Professor Changwan, I hope that your microphone is better than mine.
Thank you very nice.
Bravo, one applause. This was really an excellent talk. I was delighted to hear it. Maybe you should share it to me, please. It was really good.
Okay.
Thank you, Dr. Widdy, from very nice, useful presentation.